Hello, my name is Piotr Sobiestrik. I'm an attending physician in the cardiovascular division, vascular medicine section, and cardiac catheterization laboratory at Brigham and Women's Hospital in Boston. And I would like to discuss the management of asymptomatic carotid artery disease. The management of symptomatic carotid artery disease is well defined and concentrates on revascularization, be it with carotid endarterectomy or carotid artery stenting. But it is the asymptomatic carotid artery disease that continues to pose a clinical dilemma in many of our patients. I have no disclosures to make regarding this presentation. So let's start with a clinical question. A 79-year-old woman who lives independently, is quite well functioning, has been noted on an ultrasound to have an 80 to 99% stenosis in the right internal carotid artery. And the ultrasound was obtained after her primary care physician heard carotid bruit. And the question posed to you is, should this patient undergo revascularization? And if so, what would be the best form of revascularization? Yes or no? And that's actually a clinical vignette which was posed and then the answers were published in the New England Journal of Medicine report in 2008. And as you can see here, even 10 years ago, there was a huge or significant variability in the selected approach to this patient, depending on where the physicians practiced. And so in Australia and Asia and Russia, medical therapy was selected in almost 60% of respondents. However, in the United States and in Europe, revascularization, be it with endarterectomy or stenting, was more common. Well, what is the optimal management of a patient who has carotid artery disease? And there has certainly been a shift over the years as data from randomized controlled trials has emerged, and as medical therapy has advanced. And so in the 1990s, the two options were certainly carotid endarterectomy, or by today's standards, a rather primitive medical therapy which consisted of adding an aspirin and recommendation that smoking cessation should be attempted. And so in the symptomatic disease in that era, we had the NACET and the European study of symptomatic carotid artery disease. But in the asymptomatic realm, it was the ACAS and the ACST studies which shaped clinical practice and supported carotid endarterectomy in patients with asymptomatic disease, which exceeded 70%. And the subsequent years, in the first decade of this century, the debate concentrated not so much on whether revascularization should be offered, but rather what type of revascularization should be offered. Should it be carotid endarterectomy versus carotid artery stenting? And so in the asymptomatic patients, we had the SAPPHIRE trial, whereas in the symptomatic patients, we had the EVA3S, the SPACE, and the ICSST study. The CREST trial enrolled both symptomatic and asymptomatic patients. In this decade, while the contest between the carotid artery stenting or carotid endarterectomy is still in progress, as evidenced by the publication of the ACT1 trial, there has been more recognition and drive to focus on optimal medical therapy because of the growing recognition that many of these patients can be managed safely with modern pharmacotherapy and remain asymptomatic without the need for revascularization. And so the CREST-2 trial, which is ongoing, actually attempts or will attempt to answer whether medical therapy or revascularization should be the primary form of therapy in patients with asymptomatic carotid artery disease. So let's, for a moment, talk about the stroke risk in asymptomatic carotid artery disease. Let's talk about what the current treatment options are, and look quickly at the data supporting carotid revascularization in those who have asymptomatic carotid artery disease. And so it's important to note that carotid artery disease is not the only cause of ischemic stroke. As you can see in this slide, among all ethnic groups, lacunar strokes, cardioembolic strokes, and intracranial arterial disease all constitute a large proportion of ischemic strokes, and only about 20% of ischemic strokes can be attributed to carotid artery disease. Carotid artery stenosis, defined as a lesion of 50% or more, certainly increases with age, both in men and women. And this is certainly a clinical problem that will continue to increase in frequency as our population ages. It is also visible or seen in this slide that at least among men, each of the age groups has a higher prevalence of carotid artery stenosis, primarily those of moderate severity. The presence of a bruit is oftentimes used as a clinical driver for carotid artery ultrasound for screening purposes. It is certainly not a perfect indicator of the presence or absence of carotid artery disease, but it's still commonly used in clinical practice. Now, even back in the 1980s, before the advent and widespread use of modern medical therapy for risk factor reduction, the risk of stroke associated with a moderate to severe stenosis, up to 80% in asymptomatic patients, was relatively low, between 1 and 2% a year. And that was certainly true at a time where perioperative risk of stroke associated with carotid endarterectomy was not very different. Patients who had more severe disease certainly had a much higher risk of stroke. Nevertheless, vast majority of intervention, surgery, for many years were performed in patients who had about a 70% stenosis and whose annual risk without an intervention was not prohibitively high. And that, again, was before the era of modern medical therapy. That has to be contrasted with the fact that patients who have asymptomatic carotid artery disease, who are asymptomatic, have a significant risk of suffering a myocardial infarction or vascular death that has nothing to do with the possibility of ischemic cerebrovascular accident. Thus, these patients are more likely to suffer a myocardial infarction or a cardiovascular death than to suffer a stroke. And therefore, maybe the impetus of medical therapy should concentrate on reduction of the myocardial infarction and vascular morbidity and mortality, rather than on the reduction of ischemic stroke by offering revascularization. The other important observation is that with passage of time, improvement in medical therapy, smoking cessation, the rates of the rates of stroke in patients with carotid artery disease who are being treated medically have significantly diminished. So among patients who have carotid artery stenosis and who are asymptomatic, the risk of stroke today is much lower than it was 20 or even 30 years ago, as you can see in this meta-analysis published 9 years ago. This has certainly been supported by stroke rates in studies of carotid endarterectomy compared to medical therapy dating back to 1980s and 90s in the NACID trial and the asymptomatic trials, to a more modern studies where the stroke risk per year is vastly reduced compared to what it used to be 2 decades ago. The annual risk of stroke related to the asymptomatic carotid artery stenosis is assessed, can be assessed today as about 0.34 TIA, 1.78, and that has to be contrasted with the risk of, again, myocardial infarction, vascular death, again highlighting the importance of shifting the focus from revascularizing patients to reduce an unlikely event and concentrating more on medical therapy to prevent a more likely and life-threatening events associated with systemic atherosclerosis. It's also important to note the demographic changes in asymptomatic patients with carotid artery stenosis. The age has increased, the use of antiplatelet therapy has increased, the prevalence of ischemic heart disease has decreased, smoking is less common, atrial fibrillation has diminished, and the prevalence of atherosclerotic disease in other arterial beds has also diminished, suggesting that medical therapy and lifestyle modifications have been a significant part of the reduction in the stroke rates in patients with asymptomatic carotid artery disease. So what is the therapy for patients with carotid artery stenosis who are asymptomatic? Certainly antiplatelet agents, blood pressure control, preferably with ACE inhibitors, aggressive lipid lowering with statins has been shown to be effective. And then the question remains, who should be considered for possible revascularization? Now, the treatment, the pharmacotherapy just described certainly did not exist when the early trials of carotid endarterectomy for asymptomatic disease compared to medical therapy were started and conducted. That was all before the publication of HOPE trial, heart protection study, LIFE trial, all studies which showed a significant reduction in stroke in patients treated with angiotensin receptor blockers, ACE inhibitors, statins. The role of aspirin, on the other hand, remains somewhat controversial, widely used for stroke prevention. But as you can see, and as you can see in this women's health study of nearly 40,000 healthy women who were randomized to aspirin every other day or placebo and followed for a decade. In these patients who had very little in terms of cardiovascular risk factors, aspirin has been shown to reduce the risk of stroke and the major cardiovascular events, though not necessarily of myocardial infarction or the risk of death. And that has certainly supported the use of aspirin. The societal guidelines dating back to 2006 have certainly supported the use of aspirin among women based on the Women's Health Study to reduce the risk of stroke, though not cardiac events, as I mentioned. These recommendations were different in men, where the use of aspirin primarily resulted in reduction of cardiovascular events, though not necessarily in reduction of stroke. The importance of blood pressure control cannot be overstated when it comes to reduction of stroke risk. That, of course, is multifactorial and relevant both in patients with carotid artery disease, but also those with stroke risk related to lacunar events and hypertensive strokes. It's clear that with every degree of reduction in even diastolic blood pressure, the relative risk of stroke decreases. And in patients who have suffered a stroke, subsequent reduction in blood pressure reduces the risk of recurrent events, recurrent stroke, as seen in the PROGRESS study published almost 20 years ago. The diuretic therapy for reduction of blood pressure is quite effective in reducing the risk of stroke. And of course, calcium channel antagonists have also been shown to be effective in reducing the risk of stroke in the PREVENT trial. ACE inhibitors, just like in peripheral artery disease, have been quite popular in patients with carotid artery disease and vascular disease. And in this study, use of ACE inhibitors has been associated with a 34% relative risk reduction in the risk of stroke in asymptomatic patients. Similarly, the LIFE study documented the benefit of angiotensin receptor blockers in patients who are at high risk of stroke but who are otherwise asymptomatic, with the angiotensin receptor blockers being superior to beta blockers in terms of reducing the risk of stroke. Statins are a cornerstone of stroke prevention. In the heart protection study, there was a significant reduction in the risk of non-fatal strokes in patients randomized to treatment with simvastatin. This was also true in patients with diabetes, where statins were associated with a statistically significant decrease in risk of stroke. And so the most recent societal guidelines, published in 2011, not updated since that time, continue to support the use of antiplatelet therapy in patients with asymptomatic carotid artery disease, primarily for prevention of myocardial infarction and other ischemic cardiovascular events, less so for prevention of stroke, which has not been reliably documented in all the trials. Antihypertensive therapy is certainly recommended with blood pressure control below 140 millimeters of mercury. Statins are supported with a goal to reduce the LDL below 100 milligrams per deciliter, and for symptomatic patients to a level of 70 milligrams per deciliter, and those who are asymptomatic but who also have diabetes to the same level. And certainly in clinical practice, most practitioners would accept the same target as is used for patients with coronary artery disease. Smoking cessation is recommended, as are lifestyle modifications to increase exercise and improve glycemic control in patients with diabetes. Now, carotid revascularization trials have been a topic of many a debate, primarily trying to differentiate the pros and cons of carotid endarterectomy and carotid artery stenting. Asymptomatic carotid atherosclerosis study was a trial of carotid endarterectomy published in 1995, a study that evaluated patients with asymptomatic disease and stenosis of more than 60% in diameter. And these patients were randomized to carotid endarterectomy or contemporary medical therapy, which primarily included aspirin. And the primary outcome was ipsilateral stroke or perioperative death or stroke. And in the course of a 5-year follow-up, the study showed that the risk of major cardiovascular, that risk of major stroke or death wasn't different in these two arms. That the risk of stroke or perioperative death wasn't any different, but that the risk of ipsilateral stroke or TIA and perioperative TIA and CVA was lower in the surgical arm. The difference between these two arms in the risk of stroke and death was primarily noticeable in men and less pronounced in women who underwent surgical revascularization. That is, the benefit of carotid endarterectomy was much less pronounced in women as compared to men. The benefit of carotid endarterectomy in terms of reducing the risk of ipsilateral stroke became noticeable only after 2 years of follow-up where the curves diverged. Again, stressing the importance of individualizing these recommendations, considering patients' overall age and mortality in addition to sex. The subsequent trial of asymptomatic carotid endarterectomy, published in Lancet in 2004, included a little over 3,000 of asymptomatic patients with 60 to 99% carotid artery stenosis, and involved follow-up of 5 years. Patients were enrolled in the course of a decade. In these patients, patients who were treated with carotid endarterectomy had a statistically significant reduction in the risk of stroke, which became noticeable after 3 years of follow-up. The risk of major stroke or death was also favoring the carotid revascularization. One of the criticisms of this paper was the low adherence to optimal medical therapy, partially reflecting the decade-long enrollment process. You can appreciate that the lipid-lowering therapies, even in the early part of this century, were included only in about 50% of the patients. Blood pressure control and antiplatelet agents in the medical arm were not used to their maximum potential. Therefore, the true comparison of the efficacy of carotid endarterectomy versus optimal medical therapy has been put in question by some reviewers. The overall stroke rates in these studies have changed over the years. And so in the ACAS trial published in 1995, ipsilateral stroke was 11% in the medical arm. In the early first 5 years of enrollment in the ACST trial, it was 5%. And in the final 5 years, where the use of statins and blood pressure control and antiplatelet agents increased, that risk decreased over the 5 years to 3.6, less than 1% per year. The SAPPHIRE trial involved evaluating patients who were asymptomatic, but who, for multiple reasons, were deemed to be high-risk candidates for carotid endarterectomy and were therefore randomized to carotid artery stenosis or carotid endarterectomy. Most of these patients were asymptomatic and had high-grade stenosis exceeding 80%. The trial had a non-inferiority design, and it was one of the first trials, randomized trials, which showed that carotid artery stenting, at least in these asymptomatic patients, was non-inferior to carotid endarterectomy. The data supported this early result even after 3-year follow-up, where the freedom from major adverse events, stroke, myocardial infarction, and death was non-inferior even after 3 years of follow-up. More modern trial, the CREST trial, included patients who were of normal surgical risk, who had a discrete lesion in the internal carotid artery, and who were either symptomatic or asymptomatic. 50% of patients enrolled in this study were asymptomatic and had to have 70% or greater percent stenosis by ultrasound, or 80% stenosis by MRA or CTA. The primary endpoint at 4-year follow-up was any stroke, myocardial infarction, or death within the peri-procedural period, plus an ipsilateral stroke after the peri-procedural period. And in all comers, symptomatic or asymptomatic, the combined endpoint was similar in both groups. There was no statistically significant difference between either revascularization strategy. Now, in patients who were asymptomatic, the primary composite endpoint was also not statistically different at 30 days, and similarly was not different at 4 years. This led to the approval of this strategy, stenting, carotid artery stenting in asymptomatic patients. The peri-procedural strokes were certainly more common in patients who underwent carotid artery stenting, though they were not significantly different, either at 30 days or at 4 years. So overall, for the asymptomatic patients who underwent either carotid artery stenting or carotid endarterectomy, there was a numerical trend for a higher likelihood of suffering a myocardial infarction in patients undergoing carotid endarterectomy. The all-stroke risk was somewhat numerically higher, though not statistically significant, in the carotid artery stenting arm. The risk of A major stroke was not different. The risk of stroke and death was not statistically different either. Recent publication of a 10-year follow-up of this study continues to support equipoise in overall composite outcomes between these two revascularization strategies. And in patients who are asymptomatic, the overall risk-benefit ratio shows that either revascularization approach is reasonable in terms of stroke and death reduction, as can be seen here, not statistically significant, and certainly equipoise when it comes to the combined primary endpoint. A more recent Act 1 trial randomized patients to carotid artery stenting or carotid endarterectomy in a 3-to-1 randomization fashion. These were asymptomatic patients who were at an acceptable surgical risk for carotid endarterectomy and who had 70% stenosis or greater by angiography or duplex ultrasound. And the follow-up was extended up to 5 years. The data published recently in New England Journal of Medicine showed, again, equipoise between these two treatment strategies without significant difference between event-free survival, as described by freedom from death, stroke, and myocardial infarction at 30 days from the procedure, or ipsilateral stroke in the subsequent year. The CREST-2 trial, which has not been published, is going to add an additional arm which will comprise of medical therapy as compared to revascularization, and should shed some light on the benefit of non-revascularization, aggressive medical therapy, aggressive modern medical therapy in these patients. And so when it comes to treating asymptomatic patients with carotid artery stenosis, the treatment should be individualized. Age should be considered. Sex is important. Women derive less benefit from carotid endarterectomy, at least in the early trials. Comorbidities and operative risk are important and may either increase the threshold for any revascularization or favor stenting or carotid endarterectomy. Life expectancy is important. After all, the surgical trials have shown that the benefit occurs at 3 to 5 years. The functional status is important, and there are many lesion characteristics which will impact whether revascularization could be considered, and if so, which form of revascularization makes best sense. And so the current, though possibly outdated, societal guidelines state as a Class 2A recommendation that it is reasonable to perform carotid endarterectomy in asymptomatic patients who have stenosis of 70% or more, in whom the risk of perioperative stroke, MI, or death is low. It is reasonable to choose endarterectomy over carotid artery stenting when patients are older and when the arterial anatomy is less favorable for an endovascular intervention. However, carotid artery stenting may be superior to carotid endarterectomy when there are anatomical or medical features which increase the risk of complications associated with surgical revascularization. Prophylactic carotid artery stenting may be considered in highly selected patients with asymptomatic carotid artery stenosis, but its effectiveness compared with medical therapy alone in this situation is not well established. This is a Class B recommendation, again, emphasizing the fact that most of these patients can be safely treated with medical therapy alone, as the risk of stroke with modern therapy has been much lower than when medical therapy was compared to carotid endarterectomy. And so today we know that carotid endarterectomy is effective in stroke reduction in an asymptomatic patient in the era of absent medical therapy. We know that carotid artery stenting seems to be equivalent to carotid endarterectomy in appropriately selected patients. We know that stroke rates today are now much lower in asymptomatic carotid artery stenosis patients than they used to be. And we know that medical therapy reduces the rate of stroke and reduces the much higher rate of myocardial infarction or vascular death. And so in summary, in patients with non-coronary vascular disease and in patients with asymptomatic carotid artery disease, the primary cause of death is not necessarily stroke, but it is coronary artery disease. And therefore, the impetus of our interventions should continue to focus on optimizing medical therapy. Risk factor modification is effective in stroke risk reduction. The benefit of revascularization for asymptomatic disease is somewhat unclear in modern era of medical therapy, which involves statins, ACE inhibitors, antiplatelet agents, and blood pressure control. And we are certainly in need of a randomized clinical trial that would assess the efficacy of modern medical therapy with revascularization in these patients. It's also true that carotid artery stenting is likely equivalent to carotid endarterectomy, as seen in the most recent ACT-1 trial. Overall, the other important point to consider is that the current guidelines need to be updated. Some of the references used in preparing this presentation are listed here. And moving on to a couple of questions. The first one is, what is the estimated annual risk of stroke in patients with asymptomatic carotid artery stenosis, that is those of 50% or more? Is it A, 1 to 2%? Is it B, 2 to 3%? Is it C, 3 to 4%? Is it D, 4 to 5%? And traditionally, it's 1 to 2%, though, as I pointed out earlier, the annual risk in the most recent trials is even lower than that. In the CREST trial, which of the following was true? The carotid artery stenting arm had significantly more major strokes than carotid endarterectomy. The quality of life at 1 year was better in the carotid endarterectomy arm. Statin therapy reduced myocardial infarction and cerebrovascular accident in carotid endarterectomy, but not carotid artery stenting arms. The stroke rate after 30 days was the same in both arms. And the answer is D. There was no statistically significant difference in the 30-day stroke risk after carotid endarterectomy or carotid artery stenting. The third question, which of the following agents does not reduce stroke risk in patients with asymptomatic internal carotid artery stenosis? Aspirin, statin, angiotensin receptor blocker, angiotensin converting enzyme inhibitor. And the answer, perhaps surprisingly, is aspirin. The data for aspirin use stems from the large population trials I mentioned, but the primary benefit, especially in men, was related to reduction in myocardial infarction.